This video demonstrates a rare case of the resection of an internal carotid abscess with a great saphenous vein graft reconstruction. The patient is a 71-year-old diabetic female with end-stage renal disease who presented with right neck and face pain and swelling. She had a recent episode of MSSA and Enterobacter bacteremia that was treated with the removal of her tunneled dialysis catheter and antibiotics with apparent resolution of the infection. She denied any recent history of ipsilateral neck catheterization or trauma. Upon presentation, she was afebrile with stable vital signs and an elevated white blood cell count, and physical exam revealed poor dentition, right neck swelling, and tenderness. As you can see on the CT angiography, there was a rim-enhancing lesion that was identified that encased the right carotid bifurcation on both the axial and the coronal images. After vascular surgery and ENT evaluation, a working diagnosis of a right carotid artery secondary infection was established that was deemed due to the recent bacteremia. After obtaining blood culture and the start of IV antibiotics, the patient proceeded into surgery. So the right carotid sheath was exposed through an oblique incision across the anterior border of the sternocleidomastoid muscle, and the inflammatory orion was identified and completely dissected off the vessels so that the surgeon could obtain control of the bifurcation. Since the carotid wall was in direct contact with the pus and also appeared fairly compromised, the decision was made to replace the affected carotid portion with a graft from the great saphenous vein. And so the GSV was harvested from the right thigh, and then proximal and distal clamps were applied on the common and the internal carotid arteries. And the infected portion was resected and it was replaced by an interpositum of the reversed GSV graft. The graft was anastomosed with proximal and distal anastomoses using 6-O-proline. The external carotid artery was suture ligated. And at the end of the procedure, a satisfactory Doppler signal confirmed vessel patency, and the wound was closed. The removed ICA segment and mass were examined, and surgical pathology revealed granulation tissue with mixed inflammation and abscess formation, but no evidence of specific infectious organisms. So due to persistent neck pain and leukocytosis that the patient continued presenting with, along with a low-grade fever, on post-operative day 9, a follow-up CTA was obtained of the region, and it revealed a small fluid collection around the operative site with some gas accumulation, as you see on the right, marked by the yellow arrow. There were no definitive signs of a persistent abscess on the image, but because of the persistent symptoms, one day later on POD 10, she was taken back to the OR for exploration of the surgical site. The findings, however, were non-significant, and so the rest of her hospital stay was unremarkable. Her symptoms resolved, and she was discharged home 5 days later on oral antibiotics. And during subsequent follow-ups, she was doing well with no signs of any infection or other complications, and the wound was healing very nicely, and complete wound healing was observed. So spontaneous carotid abscess, in summary, is a rare condition and most commonly occurs as a secondary infection. And when there's a high suspicion of its presence, timely intervention is essential, because you want to have source control and also restore arterial flow or prevent thromboembolic events. I hope this was helpful, and thank you very much for your attention.